Total knee arthroplasty by Corinne Duke and Justine Schulz. Total knee arthroplasty is a surgical procedure where damaged cartilage and bone is replaced by artificial material in order to improve function and relieve pain in the knee. According to the Agency of Healthcare Research and Quality, more than 600,000 knee replacements are performed each year in the United States. The most common reasons to receive a total knee arthroplasty is rheumatoid arthritis and osteoarthritis. The average age of a person receiving a TKA is 50 to 80 years old. When diagnosing the need for a total knee arthroplasty, the physician will look at your medical history, do a physical exam, looking at the knee range of motion, strength, and alignment. X-rays are used to determine the extent of damage to the knee, and usually the X-rays will show narrowed joint space and bone spurs with osteoarthritis. An MRI may be needed to determine the condition of bone and soft tissue. Surgery will usually be recommended under certain conditions, such as severe knee pain and stiffness that limits everyday activities, chronic knee inflammation that does not improve with rest and different medications, certain knee deformities, and failure for knee pain to improve with various conservative therapies. The picture on the left shows how the knee is impacted by osteoarthritis. There is cartilage loss and joint space narrowing, creating pain and loss of function. The picture on the right is an X-ray of an individual with osteoarthritis. It shows common findings seen in the X-ray, such as reduced joint space and sclerosis, as well as osteophytes or bone spurs. The common signs and symptoms found with an individual with osteoarthritis are looking at the mechanism of injury is either a microtrauma, which will be a gradual onset, or macrotrauma. The patient may report of a deep, achy, and generalized knee pain, difficulty with performing certain activities such as climbing stairs, walking, or rising from a chair, pain after sitting for long periods of time, mechanical factors such as locking, clicking, grinding of the knee, feeling as if the knee is giving away, and increased pain with activities but is relieved when the person is at rest. The common findings in doing a physical examination on a person with osteoarthritis are usually decreased knee range of motion with popping, clicking, and grinding sounds. The person with osteoarthritis usually follows a capsular pattern with decreased knee flexion more than decreased knee extension. There also may be crepitus found with doing passive range of motion. With palpation, there may be inflammation and warmth, as well as muscle atrophy and weakness of muscles surrounding the knee, especially the quadriceps. The person may also present with gait deviations such as decreased cadence and decreased motion at the knee. There may also be patellar malalignment.
The perioperative stage of rehab is when the patient is in the hospital. This lasts for an average of 3 days. The goals for the patient at this time include pain reduction, education on restrictions, walking with safety, incision management, learning a home exercise program, and gaining knee flexion and extension. The early postoperative stage is when the patient receives home help. This lasts for 7 to 10 days after leaving the hospital. Goals at this time include neuromuscular re-education and range of motion. The patient then moves on to a postoperative stage in the outpatient clinic. Goals at this time include quad strength, functional mobility, and range of motion. Stretches are performed to the IT band, hamstrings, quadriceps, and gastrosoleus. Patella mobilizations are also done and strengthening exercises. Early therapeutic exercises include short arc quads, straight leg raises, sit to stand, standing terminal knee extension with a TheraBand, stationary bike, hamstring curls, heel raises, standing hip flexion, and standing hip abduction. Soft tissue mobilizations are done if edema is inhibiting the quads. E-stem is done if quad lag is slow to improve. The patient also participates in balance and proprioceptive training, including weight shifts, balance board, and single leg stance. To progress balance and proprioception, the patient can stand on uneven surfaces or with their eyes closed. For gait, The patient should slowly progress off an assistive device. As early as weeks 2 to 4, there were reports of patients progressing to a single cane or crutch. Through weeks 7 through 11, the patient is able to ambulate short distances without an assistive device. This is about when an endurance program should be initiated. For the late phase of therapeutic exercise, the patient should increase repetitions and resistance, participate in functional and dynamic movements, continue working on strengthening the quads, hip and core, and doing interventions such as squats, step-ups and step-downs, leg press, and wall sits. Prognosis after a total knee replacement is a full recovery, typically in 3 months. This should relieve the patient's pain, and they should require no assistive device when walking. Total knee replacement should last about 15 to 20 years until they start to loosen up and need to be replaced again. Post-op complications include stiff knee, peripheral nerve injury, infection, and quad tendon rupture. It is very important to monitor swelling, abnormal pain or gait, insufficient flexion or extension, weakness of the quads and hamstrings, and inefficient flexibility post-surgery. For a total knee patient to be discharged from outpatient therapy, they need at least 120 degrees of active knee range of motion. 100 degrees of motion is needed to get up from a low chair. Normal gait without an assistive device, 5 out of 5 quad and hamstring strength, no swelling, giving way, or pain, no extensor lag, and they must be independent with their ADLs. There are multiple outcome measures that can be used following a total knee replacement. First, there is the Knee Injury and Osteoarthritis Outcome Score. It's a 42-item survey assessing patients' opinions about difficulties with activities due to knee pain. There is no current MCID established, but the MIC is 8 to 10 points. Second is the WOMAC, which is a 24-item questionnaire with subscales in pain, stiffness, and physical function. The minimally clinically important difference for this is 15 points. Thirdly is the Knee Society Clinical Rating System, which has 2 components, a knee rating scale and a function rating scale, with an MIC of 34.5 points at 3 months. And lastly is the Oxford Knee Score, which is a knee joint-specific 12-item questionnaire that assesses pain and function. The MCID is 3 to 5 points.